Thanks, everybody. That's great. I was able to bring my husband with me up here so he could golf for 2 days. So it's been really nice that I've been able to be with you and have really enjoyed the spirited and provocative conversation over the last several days, and it's really delightful. And I thank the organizers of the conference to include me, and thank you, Guy, for the introduction. When my sister and I went to Europe when we were in college, we spent a summer kind of going to the various cities and seeing things in a very quick way and taking the train everywhere. And we did what is known as the 7-minute Louvre. You give yourself 7 minutes, you go in the Louvre, you go see the things you want to see, and then you leave because you're on track to do multiple other things. And that's what I feel like I'm doing today with the 30-minute overview of SAMHSA. And so I'm going to briskly move through some information about SAMHSA and what we're doing in the region, and then where we are on this very important topic of alternatives to medication. And I think SAMHSA is an important partner and an important advocate in a lot of the discussion that has gone on today and yesterday. I think that one of the things I want to do is to make sure that we are totally aware about the fact that SAMHSA's mission as, this is my disclosure. Everybody knows we had to do the disclosure, so there it is. SAMHSA's mission and roles are very important in terms of the context of this conversation. SAMHSA's mission is to reduce the impact of substance abuse and mental illness on America's communities. We have particular roles. That means we have a role in the federal government for voice and leadership, for funding. Obviously, we are a funding agency. We provide information and communications. We provide regulation and standard setting. And most emphatically, we are trying to focus on practice improvement, which I think has direct consequences to some of the conversation over the last 2 days. Our principles are that we want to stay focused on the goal of people. Everything should be people-oriented and person-centered. We want to make sure we are building partnerships with appropriate entities, and we want to make sure that we are measuring our performance and that we can show Congress that everyone who receives SAMHSA dollars is making a reasonable difference. This is probably the most important slide in terms of the overview, that SAMHSA is basically reflecting the Secretary's aims. Secretary Sebelius is the head of HHS, the behemoth Federal Health and Human Services Department. SAMHSA is a very small agency. Only 500 people work at SAMHSA. So SAMHSA is a very small agency in the construct of the umbrella of HHS. Secretary Sebelius has established these 3 aims: improving the nation's behavioral health, transforming healthcare in America, and achieving excellence in operations. SAMHSA then takes those aims and says, we have 8 strategic initiatives that in fact are the ways in which we make decisions about policy, program, and moving forward with budgets. Now, Congress doesn't give us money in each of these categories, but the funds that flow from Congress to SAMHSA are then shaped and focused and really transformed into these 8 strategic initiatives. The ones that I think that are most germane for your conversation here at the conference certainly is prevention, trauma and justice, recovery support. And those 3 combine to really take a look at how medications themselves are used or not used or should not be used in terms of prevention of mental illnesses and substance abuse disorders, the effects of trauma, and the fact that SAMHSA takes a position that we believe that trauma is a universal experience for many, many people, particularly individuals who have these conditions, and in fact recovery support, which is where all of our portfolio about building recovery and recovery supports within the systems of care rest. And so those are the 3 strategic initiative areas that I think are probably the most important. SAMHSA also takes a very strong public health approach. That means instead of being, quote, a social services or human services agency, SAMHSA is now perceived as a public health agency. And what that means, again, is that we have to be focusing on prevalence and surveillance data, looking at the community as a whole, taking the public health model and making sure that we're looking at the commonalities of communities. That's often why SAMHSA reports on sub-state and state prevalence and incidence rates, so that we can see this as not only an individual condition, but also that there are environmental circumstances that are hugely important when it comes to addressing behavioral health issues. And from the standpoint of SAMHSA, we use the term behavioral health to mean mental and substance use conditions. which is the IOM terminology. And in fact, as David was talking this morning, this whole notion about talking about the clusters of mental illnesses, substance abuse disorders, addictions, etc., all of that really falls into the emotional and mental well-being construct and the focus on wellness, which is actually part of our prevention initiative. And yet we constantly are reframing behavioral health in terms of mental and substance use conditions, which at the heart of the message, basically, is that the mind and the body are inseparable. And so the thrust for SAMHSA is to step out that messaging, which you saw on the first slide, that behavioral health is essential to health, that people recover, that treatment is effective. And in fact, our probably the strongest theme that we have is to try to build that message into all of Americans. I don't think all of America accepts that message yet. I think that many of them still believe in the separability of the mind and the body. I still think that they take behavioral health issues and put them over here and think about them as character. And I still think that there's a lot of issues related to building the fact that behavioral health is essential to health. Mental health is fundamental to well-being. Surgeon General Satcher made it very clear. The mind, the brain is the seat of cognition, emotion, and memory. It, in fact, can have conditions affecting it as any other body part. And so it's a hugely important message for us in terms of behavioral health. Our recovery working definition is the foundation on which we are going to be talking about the use of medications. I put the new brochure at the back table. This is SAMHSA's working definition of recovery. It also includes many of the principles of recovery. And this is the construct in which we as an organization need to move forward and say, since behavioral health is essential to health, recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to achieve their full potential. That's the basis for the definition. And let me tell you how important it is for SAMHSA to have finally done this, because for too long we were having debates about what recovery meant in the substance abuse field and what an addiction field and what recovery meant for mental illness. And so, in fact, we have come to a congruent place where we believe that we need to influence the other payers. And that's why we did this. We want to influence the other payers. That means CMS. That means HRSA. That means Medicare and Medicaid. That means insurance companies. That means all the people who pay for health services. We want them to understand what we mean by recovery and how we define recovery and what are the services and interventions and supports that are essential for recovery. And we want them to be covered as appropriate in healthcare reform. So our fourth strategic initiative is recovery support. What we're doing in that initiative is partnering with people in recovery from mental and substance use disorders and family members to guide the behavioral health system, to promote individual, program, and systemic level approaches that foster health and resilience, that increase permanent housing, that focus on supported and competitive employment, that look at supported education, and all other necessary supports. These things in here really are the names of SAMHSA's programs. We have a supported education program, we have a supported housing program, we have all of those are the named programs, and also a recovery-oriented systems of care program. So you'll see that those aspects of recovery support are important to us. I know you can't read this, but this is the way in which we track how we're focusing on recovery supports. And we try very hard to make sure that the recovery support portfolio that we have covers the 4 dimensions that we think are important for a life in the community and recovery: home, health, community, and purpose. So most of our portfolio in our competitive and discretionary programs focuses on some aspect of those 4 dimensions. We want people in recovery to be addressing their home situation in terms of stable and permanent housing, their health in terms of wellness and nutrition, and appropriate supports for their future lives in terms of controlling their health, community in terms of making sure they're connected with individual supports, and purpose, that there is employment opportunity and volunteering opportunities, et cetera. And that's really the layout of this strategic initiative. Now, one of the things that we're struggling with is that in the context of recovery, how do you go about proving that recovery and those kinds of supports and interventions that are necessary for recovery meet the test of what is medically necessary? because the payers, that is Medicaid and Medicare, want to make sure that what they are supporting and paying for is medically necessary. So our recovery statement helps trigger the fact that we know that it's a process of change through which individuals improve. You take a look at CMS's definition of what is medically necessary. The patient must have a significant health problem, and the services rendered must have a direct therapeutic relationship to the patient's condition and provide reasonable expectation of recovery or improvement of function. We don't think they're very far from each other. And that's our basis for pushing out our discussion. My new best friends at the regional level are CMS and HRSA and ACF and all the other federal partners who pay for health services, but they've never heard about recovery. And so consequently, we're trying to build that important impression and that important statement. I'm going to not spend time on the recovery continuum. You'll see these slides. This is just a basic analysis about how the recovery continuum crosswalks with Maslow's hierarchy of needs, and where in fact the line of what current payment and current support does in the health and insurance system responsibility, that is the health, home, community purpose services. These are things that the insurance systems will pay for. And in fact, what happens is that there's a very fine line in the recovery journey in which everything then devolves to personal responsibility, and insurers do not pay for those kinds of supports. So our hope is that we keep on building a higher level of responsibility and understanding about what is needed for a life in recovery, and in turn, who should be supporting that and who should be paying for it. I think that the next, I'm not going on here. There we go. Our recovery principles, 10 dynamic principles, and they are also included in the brochure. We think that this is a great tool when you start having conversations between individuals who have these conditions and their psychiatrists and their case managers and their psychologists and their social workers, to begin to have a conversation about what recovery means and how, in fact, the services that are being delivered actually reflect these particular principles. The most important one, of course, being hope. That's been mentioned oftentimes throughout the last several days about how instilling hope and hopefulness is really a part of what services should all be about. But there's a whole definition of each of these principles in the brochure that I think is a wonderful conversation starter, particularly between medical practitioners and consumers. In terms of looking at the working definition of recovery, we now have to proceed very vigorously to make sure that you, in all of your states, as you look at your networking exchanges and create what the Affordable Care Act is going to provide for you in your networking exchanges, that there is a defined array of recovery support services that are going to be included. SAMHSA has done a paper called the Good and Modern paper, which lists out the kinds of services that we think are appropriate, which we gave to CMS, that should in fact ground recovery in outcomes. It's wonderful to say peer support services are part of that. What are the impact and the outcomes that should be measured in terms of peer support services, and how do we need to move forward, and making sure that these are quality services, that we're measuring them, that we're moving forward. That's how the payers are going to pay attention, and that's how we're going to get recovery really embedded in our systems. All right, there's a whole variety of tools that SAMHSA has been working on, and I'm just going to very specifically go over the fact that we refer to a set of tools that help in recovery as either self-management tools, self-directed care tools, or shared decision-making tools. And in fact, we think that shared decision-making really helps provide the direction for the future. That is, you're determining in a shared environment the direction of your care with your practitioner. And we think that by using shared decision-making tools, it increases the knowledge about and the comfort of decisions that are being made. And we have really a host of these tools that are available through the SAMHSA website. Last October, SAMHSA convened for the first time a psychopharmacological dialogue. And in fact, at that time, we began to take a look at what are some alternatives to medication. And SAMHSA brought in a host of, quote, experts who had beliefs about the way in which medication should be used. And so that meeting in October, the minutes are being compiled from that meeting, and I think that's going to be one of the most important tools that SAMHSA will have in terms of how to incorporate the recommendations from that dialogue into some of our shared decision-making tools. We think that the shared decision-making approach is the framework in which the journey to recovery really can be grounded and it can be focused. And I think that we have taken the position from the October dialogue that the use of medications is very complex, it's very dynamic and evolves over time. We are in fact trying to think about ways in which we can increase individuals' participation in informed choices, and I've heard over the last 2 days several methods for that, which is really wonderful. We do consider medication to be a tool in the recovery arsenal and in the recovery process, and in fact we hope that that continues to be thought of as a possible way of an individual making a choice about which tools in the toolkit that individual would like to use. We know it's important to look at the use of medications in terms of ethnicity, the impacts on children, and the morbidity and mortality information relative to usage, treatment practices, and protocols. We know those are all important parts, and I think that this conference has really reiterated that in terms of focusing on why each of these aspects are important. I think that there are tremendous, tremendous resources that are available in terms of where the federal government is looking at this issue. You all know that the Government Accounting Office has looked very closely at the prescription of psychotropic medications in foster care and in child care. There's a huge amount of work going on in terms of CMS looking at the targeting of antipsychotics in nursing home residents. There are a host of shared decision-making tools at this website for SAMHSA. There's also a host of them at this particular website for consumer survivors. The Devon Partnership of the National Health Service in England has established memory cafes, going from strength to strength and using, taking individuals who are experiencing dementia and their carers and creating a supportive environment in which to care for, share experiences, and their resource information is here. So there's a lot of different analysis and exploration and investigation going on that I think is very helpful and very helpful to looking at the future and the way in which the recovery construct will in fact be able to analyze how medications may have a role in the self-management of a condition. We also at SAMHSA have a special program called Recovery to Practice. This is a TA center, a resource center, and this resource center is headed by Dr. Larry Davidson from Yale, and it is a source of information about how do you develop recovery-oriented systems and how are those systems supposed to be structured? How do you make the decisions in your practice about the way in which to reflect the recovery philosophy and the recovery principles? Each profession has a unique role, and the Resource Center is using a wide variety of communications. There are weekly updates in this effort, and there's a host of information about how do you make your community mental health center or substance abuse agency recovery friendly? What should you do? What should it look like? How should you adapt your communication practices and your intervention practices to be recovery friendly? You know, there are just tremendous ways in which we need to be thinking about how we can build recovery into practice and how we can make it more the universal expectation and not the exception. Then there's a special opportunity in looking at recovery-oriented prescribing. We, of course, are committed to being informed by the individual recovery experience, and in fact, we want to make sure that we're providing information and guidance to practitioners. So our Recovery to Practice initiative is now creating 5 distinct recovery-oriented, I think the best word would be toolkits, guidelines, for the distinct practices. APA, both APAs, the Council on Social Work Education, the American Nurses Association, all of those trade associations are looking at ways in which they believe that it might be appropriate to adapt their practices so that they become much more recovery-oriented. There's a whole host of terms that I've heard over the last couple of days. And self-directed care is one of them, and personal medicine is another one that I've heard used. And the person who I heard use that was Patricia Deegan, who is one of the most famous and wonderful advocates in this field. And when she talks about personal medicine, she talks about it in a way that comprises things that are self-taught, that are non-pharmaceutical strategies that people with mental illnesses can use, often in combination with other medications to advance their recovery and improve their lives. Sometimes it is with medication, sometimes it's not. But the whole notion of thinking about yourself as your personal medicine doctor and thinking about the way in which you need to combine things, yoga, fishing, parenting, repairing airplanes, exercising, caring for pets, friendship, working on puzzles, all of those things are a part of the life that you create, and all of them can, in fact, be encouraging a range of supports that are creative, that reflect your individual life, and that really continuously invoke your work in your own recovery. I think that we at SAMHSA believe that much of the work in the shared decision-making and personal medicine approach are really the future for individuals with mental and substance use conditions. And we are honored to join with all of you on your journeys to recovery. And I think most importantly, I think that SAMHSA will continue to explore this issue. We are unafraid to begin to say it's important for us to look at the use of medications. It's important for us to have that conversation and that debate. And that's why I think I've been so privileged to be able to participate in what you've done over the last few days. Basically, the right medicine at the right dose for the right person at the right time can in fact save a life, broadly in medicine, not just in behavioral health conditions. But the wrong medication or the wrong dose for the wrong person at the wrong time can actually end it. I think that the safe use of medication or the choice about using medication in the effective treatment of behavioral health conditions is too important a topic to ignore, and I applaud the state of Maine for looking at this. As the nation's voice on behavioral health, SAMHSA is committed to providing guidance to practitioners and to other stakeholders on ways to ensure that individuals with behavioral health conditions and their loved ones are fully informed, fully educated, and fully empowered to make informed decisions about the use or non-use of effective medications and tools. I want to thank you very much for having me with you today, and have a great conference. Thank you.